All right, just a moment. I'm gonna start sharing my slides. I see them. All right, we can go ahead and get started. I'm gonna see if I can get my actual computer to work, but we can make things work with the phone. Welcome everyone to Jerry Pell Grand Rounds. Yuliya, Speroff, and James Sherrell are going to talk to us about some very important topics. One of the reasons I love working at Harborview Medical Center is because of the culturally competent care and health equity that everyone focuses on here to serve our mission population. And I have always been so grateful for interpreter services, for the cultural mediators, and I am blown away by the resources of ethnomed.org, all of these things that help support us to take really good care of our patients. And so I am very grateful that you're coming to talk to us today about how to utilize these resources to take really good care of our patients and connect them with the resources that help them thrive. So take it away. Thank you so much. Yeah, thank you so much for the warm welcome. James and I are here to tell you about how our department can support you in taking care of patients and their families when there is a language barrier, where there is a cultural barrier. And in my part of the presentation, I'll go over probably some of this might be a refresher for you rather than brand new information, but I'll go over why our department even exists in the first place and the hospital's responsibility in providing language access. I'll talk to you about all of the logistics of how to request an interpreter, how to request a written translation. And then I'll finish with a discussion of some of the challenges that are specific to your specialties. And then James will take over and talk about all of the amazing things that Ethnomed has available and partnership opportunities. But first, I'll briefly introduce myself. So my name is Yuliya Speroff. I'm a supervisor with Harborview Interpreter Services. I have been here for 5 years, just had my anniversary. And I'm a certified Russian interpreter myself. So sometimes you'll also hear me saying we when I speak to interpreters. That is why I may have even interpreted for one of you before. Before we start, though, some of these discussions can be difficult, especially if we bring up case studies. So I wanted to start with some pet therapy. Actually, this is particularly appropriate for geriatric medicine because this is Jackie and she's 10. And in dog years, she's officially a geriatric patient. So I thought you'd appreciate seeing one that is so cute. Um, I also stole this idea from a GI resident who, spiced up their presentation about Crohn's disease with pictures of their dog. Now that we've been healed by pictures of Jackie, I do have a question for you. So I would so that I can shape my presentation better, I would love to hear when you take care of patients when there is a language and cultural barrier, what are some of the issues that you have run into or typically run into? And you're welcome to share by typing in the chat or by maybe taking yourself off mute if you'd like to say something.
Hi everyone, my name is Rofan. Thank you for having us here. So I think one of the challenges that we usually have, but I think it also depends on the interpreter. But sometimes I know like when patients try to express something, it's not really interpreted correctly. And then we have this frustration, both sides trying to understand each other. And I think especially hard when you have a geriatric patient, people with the dementia. you're trying to understand some words, but it's also so challenging for the interpreter to let you know what exactly words that they're talking about. And I think that really makes it difficult.
Mm-hmm, mm-hmm. Thank you for sharing that. I will talk a little bit about how to maybe navigate this challenge of things getting lost in translation potentially, but yes, this is definitely tricky. Mm. And somebody's sharing as a spiritual care provider, there are natural pauses when I'd like to offer empathy, but the timing is misplaced. That is really, really hard. I will share that I volunteer for a program that supports survivors of domestic violence, and a big part of it is just offering empathy and compassion and validation. And I've definitely been in situations where with my voice, I say things like, "Oh, I'm so, so sorry," and things like that, and the interpreter is very, very efficient. And they're like, "I'm very sorry. I'm so sorry to hear you going through this." And it might be part of it might be cultural, because I think it's not always easy to gauge whether speakers of other language are conveying that. But a lot of the times, interpreters are trained to do that. I'm seeing a lot of comments in the chat. Older adults with hearing impaired, that is a real challenge for everyone. The amount of information required, yes. Um, and I think this is just something that no amount of like technology or anything else will ever eliminate the fact that it's
Uh,
going to be twice as long with an interpreter.
no,
I
no,
think,
no. I'm sorry. Oh, can I just
yes,
comment?
of
Because
course.
we've actually tallied this on MedD when we have 10 or 11 patients who need an interpreter. Why can't there just be a scan of their band? I've literally had the interpreter have to go back and forth with the resident because we say 6 East and they're like, no, we need the service. And we're like, okay, medicine D. No, medicine D. No, it's not medicine D. Oh, acute medicine. No, we don't have acute medicine. And then having to spell out very, very long entire patient names. And we were just wondering, why can't we just scan in the patient's band? Or do
Yeah.
something to make it a little bit more efficient. It's just really a lot of details that are time consuming when you add up, when you have a lot of patients who need that service.
Yeah, thank you for this question. I love the idea of a band scan. I think the technology just isn't there. I know we are working with our main vendor on integration with Epic. And so, and that is intended to work sort of how you described it, right? Where you like either scan something or you're already logged into the patient's chart. While we are working on this, we do unfortunately have to collect this information. It's part of our regulatory requirements, so that, if the Joint Commission came, for example, and said like, "Oh, we have this patient, did we provide interpreter services for them?" And we can say, "Yes, here are the logs that we can pull from our vendors where it shows, who interpreted for them and at what time and what service." So that is kind of necessary for now, but we recognize that it does place a burden. And so we are working to have it integrated with Epic. All right. Well, thank you so much for your questions and for your comments. I think, some of these things I have some answers for you, some of them I do not, and that's just how it works. But I also want to say, as part of my job, I do speak to patients with whose language of care is other than English. So I know what it feels like to have to connect to an interpreter and speaking through an interpreter. So I do recognize there are a lot of challenges around this, but we also know that the challenges that we face are mirrored by the challenges that patients face as well. And so there is unfortunately a lot of research that shows that having limited English proficiency is a huge social determinant of health. And there are so many risks associated with the ability to speak English, from delay in diagnosis to longer hospital stays, which I'm sure you realize, on average, it's 2.5 days longer in a hospital, which you recognize this is a risk to the patient. Greater risk of surgery and procedure delays and cancellation, because if the patient doesn't know not to eat before surgery or doesn't know how to prep for a colonoscopy, if these things are elective, clearly they're not going to happen. And then greater chance of hospital readmissions, which we know something that we do not want. And so the good news is that these risks, these adverse outcomes can be alleviated when we provide language services, whether it is professional interpreters, whether it is document translation, whether it is other things that we can provide. So there are solid clinical reasons and safety reasons for why our department exists, for why language services are provided. We also have a legal responsibility as a federally funded institution. Language access is mandated by such laws as Civil Rights Act. Title VI, for example, says that federally funded institutions cannot discriminate against anyone based on the color of the skin, based on race, based on national origin. So national origin is associated with the ability to speak English. Similarly, Section 157 of the Affordable Care Act and the Americans with Disabilities Act. We also have regulatory requirements, which I sort of mentioned a few minutes ago when I was speaking about why we need to document interpreted encounters. But the Joint Commission requires us to ask patients what their preferred language is. So we go by preferred language, right? We don't give patients an English test on admission. We ask what is the language that they prefer to communicate about their health in. And then we have to document it, and we have to provide whatever it is that the patient asked for. And so these are federal laws, right? And the Joint Commission works across the US. So you'd think every hospital, every clinic would have an interpreter services department, but I'm sure you know that that's not the case. Different institutions provide language services differently based on what's available to them, based on their location, sometimes based on kind of the climate in the state as well. And so that's why I think we're very fortunate here at Harborview. We have a really robust interpreter services department. So under the umbrella of interpreter services, we actually have 3 programs. One program is interpretation and translation. So this is where we offer interpreting and document translation. Community house calls, where we have our amazing caseworkers, cultural mediators, and then ethnomed.org that James will tell you in more detail about. Our department stays pretty busy. At Harborview, the patients with language of care other than English account for about 17%. Just to compare, at Montlake, it's about 9%. Our department receives between 400 to 500 requests every day, and we serve over 140 languages throughout the year. On staff, we have 17 languages, and the top languages here at Harborview are Spanish, Vietnamese, Somali, Amharic and Tigrinya, Cantonese and Mandarin, Arabic, Dari, Farsi, Pashto, and Russian. But we have a few more languages on staff that are not listed here. So even though we have a really robust team, we have 22 medical interpreters, or 23 medical interpreters. We also have 13 caseworkers, cultural mediators. We still can't cover all of the requests that you're seeing on this slide, right? Up to 500 requests every day, up to 140 languages every year. So we partner with vendors. These are large language service providers that have interpreters working all over the US. And so they help us by providing telephonic service and video services. So when you're calling an interpreter on the phone or when you connect with one over the video, most of the time, this is not one of our staff interpreters. This is somebody who works for our vendor. So these are all of the ways you can request an interpreter. So we have in-person interpretation. These are our staff interpreters. In order to request one, you can always call our mainline phone number. And I'm happy to send you some badge buddies where it lists our main phone number. When you call this number, you're presented with options. It will ask you to press 1 to speak to a member of the scheduling team. You can also call or fax requests ahead of time, or you can indicate in appointment notes. that you would like an in-person interpreter. We usually ask you to include a brief reason. So maybe patient is hard of hearing, patient is cognitively impaired. And so on your speed dial, I love that. And why do we ask you to do that? Why do we ask you to explain why you're requesting an in-person interpreter? Again, I would like to refer you to the previous slide and the fact of how many requests we receive. If you look at census, out of all of the patients at Harborview on any given day, about 60 of them will have language of care other than English. About 30 of them will be Spanish speakers. So on any given day, we have about 30 Spanish speakers just on the inpatient side, and maybe a couple hundred more coming to outpatient appointments. We have 10 Spanish interpreters, which sounds like a lot, but they still cannot cover every single appointment for Spanish. So we have to really prioritize and think, who would be really struggling to use a phone or video, either because of their own condition or because of the nature of the conversation, right? Whether it's physical therapy with a lot of instructions, a lot of hands-on things happening, whether it is goals of care discussion that's very delicate and involves a lot of family members. So you can always request an interpreter. The worst we'll do is we'll say no, but we really try to honor requests, particularly because we realize both palliative care and geriatric care have these unique challenges, and patients may have these unique communication needs. For everything else, we have telephonic interpretation. So the great thing about telephonic is that it's available 24/7. You can use any phone. You can use the desk phone, a conference phone. You can use an iPhone. Most inpatient units have iPhones. And so even if it's your personal phone, you will not be charged for anything. And another cool thing about telephonic interpretation is that if there is a rare language that you're consistently having difficulty accessing, we can pre-schedule for this language. Either way, if you're having any issues, let's say you called and you're trying to get an interpreter, you're on hold for a long time, something else is happening, please call again that number 49250 and press 1 to talk to a member of the scheduling team. There's a number of things we can do. We can transfer you to our secondary agency. We can call the agency and figure out what's going on and why it is that you cannot get a language that you need. So if you're having troubles accessing an interpreter through a phone, please let us know during business hours. And also, if you had any other things that didn't go great, like maybe you had an interpreter that wasn't doing an amazing job or something else happened, you can always report it to us. Even though it is our vendor, we can absolutely follow up. They do record conversations, so there is an opportunity there to follow up. We also have video interpretation available. Okay, here is the point in the presentation where I ask for your participation again. Have you seen a TV show on HBO called The Pit? You can say yes if you have, you can post in the chat. And I'm also curious, if you have seen it, what are your thoughts on its accuracy? TV show called The Pit on HBO. Have you seen it? And if yes, what are your thoughts on its accuracy? Okay, I have a couple of not yets. If you said yes, what did you think? Were there any parts that you thought were wildly inaccurate or wildly accurate? Okay, for those that said no, this is a show. If you've seen the original medical show, The ER, and you remember Dr. Carter, it's the same actor. And it's set in the emergency department in a hospital in Pittsburgh, hence The Pit. The whole season is just one shift in that ED. So each episode is 1 hour in the life of the emergency department. And this TV show has really been recognized as being more accurate than any other TV show in terms of medicine. Although I will say the emergency medicine said that they liked it, but OBGYN did not like it. Why do I bring it up? because it's also accurate in the way that it portrays cross-cultural medicine. Let's take Grey's Anatomy, for example. It has been on air for 22 years. I love it. I've watched it a lot of times. They haven't shown an interpreter once. And here we have the pit. Within the first episode, they roll out a tablet, and it is exactly the same tablet as we use here at Harborview, the same company. And guess what? The person you see on the screen is a real Nepali interpreter. Moreover, the doctor here is really modeling excellent partnership with an interpreter by looking directly at the patient and speaking to them directly. So I just wanted you to think that if you're thinking, I need an interpreter, where do I get one? If you have seen the pit, then you could it might remind you to look for a green tablet. So here we have our green tablets. They are available on most, not most, all inpatient floors and clinics. Also, we can set them up on your computer. Ideally, your computer will have two screens. It will need to have a webcam and some sort of sound output device. But once you have that, we can easily install the actual app on your computer. Another interesting thing about the tablet. So when you're using the tablet, you will connect to an interpreter, right? You have this menu. You have, all of the languages. When you click on one, you get connected to an interpreter on video. So this is not like a robot or avatar. This is a real interpreter. You kind of call them on Zoom. If the language that you need is not available on that menu, there is a button that says audio only. So you can click that button, and that gives you access to dozens more languages on the same device without having to now go and find a phone. Again, these tablets are maintained by us, Interpreter Services. So if there are any issues with the tablets you're working with, let us know. And then finally, in addition to these interpretation services, in person and remote, we also offer document translation. To request a document to be translated, we have an email, hmctranslation@uw.edu. We translate documents at no cost to your department or yourself. Some of the things we can translate is patient education. So for example, if you know UW Medicine Health Online, it has a lot of patient education documents for UW Medicine. Some of them are translated. So one example, brain death. What is brain death? This has been translated to something like 13 languages. If you have patient education materials that you consistently share with your patients, consider sending them to us so you'll have them available in the most common languages. We can also translate AVS or discharge instructions. Now, our turnaround time is a couple of business days. So please know if you have a patient discharging in the next hour, we're unlikely to be able to turn it around. If you have a patient in your office right now and you want to have their AVS translated, again, we're unlikely to be able to help, but you could have a conversation with your patient and say, this is a very tricky regimen that I'm prescribing you, a lot of complex information. I can get it to you in Spanish, but it'll take a couple of business days. Could I send it to you in my chart? Could we mail it to you? And we can actually mail it to patients. So other things we can translate and have translated are letters to patients. So for example, there's a patient you can't reach. And so we have translated things like, hey, we've been calling you, please make an appointment with us. It's really important. And then finally, forms. If you have like symptom checker, any other forms, we can also get those translated. All right. So we talked about how providing language services is our legal responsibility, and it also makes sense in terms of safe, quality care. So somebody should interpret, but who? I think this will be particularly important for maybe geriatric care, but also palliative care. We know that patients usually come with their family members, and they may expect to have to interpret. It is not allowed here at Harborview and across all of the UW Medicine. Can you think of why we don't want family members to interpret?
And I think I have this encounter like when family they think they understand those medical terms, but actually they are not really, interpreting in the right way. And I
Mm-hmm.
also see, especially with elder patients, dementia, they come in
Mm-hmm.
with family members. Sometimes you want to listen to the patient first, but in a family, they will kind of step in and give their opinion. And I think it's kind of caused a barrier. You can't really get to the patient directly.
Mm-hmm. Thank you. Absolutely. And I'm seeing some comments in the chat as well that are absolutely on point. Yes, so there are many reasons why family members may not interpret everything to the patient or everything that the patient says. So it could be conflict of interest. It could be we're keeping information from the patient to keep from upsetting them, right? This prevalent in many cultures, including the Russian speaking culture. As an interpreter, I have been asked by family members not to interpret the word cancer. So they would say, my father doesn't know he has cancer, even though we've been coming to this cancer care center for the last couple of months. So when you interpret, do not say cancer, say something else. I cannot do that, right? Or we also cannot discount situations where there is abuse happening. And so we don't really want one person to control everything that the patient hears and everything the patient says. And finally, patient autonomy. There was a study that showed that older patients who had family members interpreting for them had no sense of autonomy when it came to their medical decision making. So these are all really good reasons, but patients and or their family members may still insist. So what can we say to discourage them? Sometimes just saying, this is a policy, we do have to have an interpreter present. Sometimes that's what works. Sometimes it's kind of trying to figure out why, what is the resistance? Is it that they're worried it will cost them? Is it that they are concerned about confidentiality? And so kind of talking through this, how there's no charge and interpreters have to maintain confidentiality, same as doctors, or maybe even switching from an in-person to telephonic interpreter, because that can feel more kind of, more private. Um, if you ended up having a family member interpret, like I'm thinking particularly a patient with dementia, and as an interpreter, I have had challenges where when I interpret, they look at me and they're like, "Who are you and why are you talking to me?" And they're absolutely not able to take in anything I interpret. And so I had to interpret to a family member. The family member had to repeat everything I said for the patient. So if anything like that happens, or maybe it's an emergency and you're working on getting an interpreter, but first you had a family member interpret. We want to document it and we want to make sure to say, we made 3 attempts to reach a telephonic interpreter. We weren't able to. So this is what we ended up doing. Do we have folks here who speak a language other than English fluently?
I'm from China, so I do speak Mandarin.
Amazing. And I'm seeing another yes in the chat. You know what? I don't know if you had a chance to work with our in-person interpreters. They're really loved by patients and by staff. But what patients love even more is a provider who speaks their own language. We also love that for you, but we do have a responsibility to make sure that whoever speaks to the patient is qualified to do so, right? When we hire interpreters, we make sure they're certified, or we make sure they're tested. So same with everyone else. So this slide is for you. You could have a look at it afterwards. And so what you will need to do is email bilingual staff at UW.edu. They'll sign you up for a free assessment. Once you get assessed, you will have a badge buddy that identifies you as speaking that language. You can then provide patient care within the scope of your role, meaning you cannot interpret for your colleagues because that is not part of your job, but you can perform your job in that language and now you're covered. So that if the Joint Commission comes and says, "Oh, this patient speaks Amharic, but I don't see a record of the interpreter," we will say, "Well, this doctor speaks Amharic. How do you know?" We had them tested and we have this documented, right? So then we are all covered. So family members cannot interpret. Co-workers cannot interpret. Okay, let's talk about one more entity that also cannot interpret, but let me address a question. What is our responsibility when we notice that interpreter is not interpreting as accurately as I would like? Um, that's a really good question. You could always disconnect and get a different interpreter and then report it to us so that we can have the company follow up. And so they can maybe send them for more training or not have them interpret anymore. So that's one thing you could do. You could also redirect the interpreter. That may or may not help, but you could redirect them and say, can you please interpret everything exactly as it's being said? And that can happen. I'm sure you all realize there is sometimes you say one sentence, the interpreter has to say a couple of sentences. So sometimes there is language growth, but it shouldn't be where you said one sentence and the interpreter said like 3 paragraphs, or you said 3 paragraphs and the interpreter said one sentence. So you can absolutely prompt them. And if that hasn't helped, hang up and call back. Okay, not family members, not coworkers, also not Google Translate. I will say Google Translate or ChatGPT or any other AI-powered machine translation has gotten better. It is a great tool for us professional interpreters and translators. But let's think about this. We now have UW Medicine Chat, which is a safe version of ChatGPT, right? You can use it in your work to help you. But you wouldn't put in and say, write me discharge instructions for a patient with this condition. If you did that, you'd review these discharge instructions to make sure that it didn't hallucinate anything, that it didn't put there anything untrue or unsafe, right? And these are, in fact, the rules of using these tools. It says that the final liability is with you, the physician. Whatever you create using these tools, you have to verify. It is the same with translations. If something was translated into Spanish or Amharic or Arabic, it has to be verified. Well, what if you don't speak Spanish, Arabic, or Amharic? That means you cannot verify it. And that means you cannot give it to the patient. It is not safe, especially for languages other than Spanish, right? We keep testing them out and we keep finding major errors, including in Spanish, where, for example, where you say, please hold this medication, meaning temporarily stop taking it, it will say, keep taking this medication. And this can have catastrophic consequences, as I'm sure you can imagine with many medications. And I understand, I'm telling you, it will take a couple of business days to translate things, and Google Translate does it in 30 seconds or less. I understand the kind of temptation, but it's just not safe. All right. I have just a couple more slides before I give it over to James. So the phone number that we talked about that some of you have on speed dial is staff facing. It's for you, not for the patients. But recently we came up with preferred language line. So this is where a patient calls a number to reach UW Medicine and they get connected to an interpreter first. Dot phrase is in the works to have it available to you in Epic, so you can just put it in the AVS. For now, you may want to save this, and I can also send you, we have like a one-pager that has all of these languages, and it says, for example, in Russian, to call UW Medicine in Russian, call this number. And so this really makes it easier for patients to navigate the phone tree so that they can reach a patient who is staying in the hospital, or they can reach your clinic, or they can reach financial counseling. This is really revolutionary. And then another important point, I talked a little bit about documentation and our regulatory and legal responsibilities in providing language services. To document your service, to document your work with language services, add interpreter use and choose the appropriate option. Whether you spoke to the patient in Amharic, whether you had a phone interpreter or an in-person interpreter, we want to make sure that every single encounter is documented. Finally, when you're partnering with an interpreter, again, I'm sure you are already doing this, but just a quick refresher. Let's say you're calling a telephonic interpreter. Here you are at Harborview. The interpreter is in Wisconsin. They don't know Harborview. They don't know who you are. So giving them a very brief orientation. I am Dr. Speroff. I'm just outside the patient's room. I'm going to go in and we'll discuss some test results and come up with a plan. And it kind of helps them orient to what's about to happen. Or particularly, maybe you're about to share some bad news. It might be helpful to give an interpreter little heads up. I already talked about directing the interpreter to interpret everything as it's being said. This is something we're supposed to do as interpreters. Might be a helpful reminder, particularly if you're working with a patient that has, something going on cognitively that may be confusing. So maybe telling the interpreter interpret everything as it's being said, even if it's incoherent or even if it's repeated. Remember to speak to the patient directly, or their family member, just like you would to an English speaking patient, right? Not to the interpreter, but to the patient. And then remember to pause from time to time to allow the interpreter to interpret, and consider doing teach back, particularly if you had a lot of information to impart. Tell me again, how will you take your new medication? And what are some signs that you need to call 911? And what is hospice? What is your understanding of hospice? Why do you think we're bringing this up now? And that brings me to my last slide. And some of the and in fact, I'll stop sharing for a second. Just so that we can focus on each other. When it comes to palliative care, when it comes to discussing this, these are delicate conversations, even if it's not end of life. And in many countries, palliative care doesn't exist, or if it exists, for example, hospice is a place where we send old people to die. And that is that. And that is a sign that the doctors are giving up and are not going to do anything for you. In some cultures, there is very strong taboo around discussing anything to do with end of life. A Chinese interpreter at Montlake talked about how, they think the hospital should try to save the patient's life until the very last moment. So even if the doctors explained, there's no treatment, this is it, they still expect the doctors to do everything they could. So talking about anything to do with end of life too soon may give an impression of everybody just giving up. So you may want to check in with an interpreter before starting these conversations. An interpreter will not know potentially the specific family. They will not know the mood and the culture, but they may give you some understanding of, in a particular culture, what are some general thoughts around these topics. And another thing I want to counsel you against is very vague language. As an interpreter, some of the things I heard doctors say were, you've been through a lot. It's time to look at the big picture. Would you like to talk to a team that can help you do that? Now, because I've interpreted for this patient for a while, I knew what they were saying. They were saying, your chemo's not working. It's making you sicker. Let's talk about quality of life and involving palliative care for that care, right? The patient did not understand any of that and just said, another team, I have 10 doctors already, I don't need this. Or saying things like, we're going to keep you comfortable. And the patient goes, oh my gosh, thank you. Yes. Because to them, being kept comfortable actually sounds great, right? My hospital bed is not amazing. My pillow is flat. So I welcome the idea of being made more comfortable. Again, without discussion of what it actually means. So in this situation, similarly doing teach back, asking the patients what they understand, and then really educating them on what palliative care is and isn't, why it is being involved, and what it does not mean, right? Like we're not giving up and things like that. All right. Thank you so much for listening to me. If you have any questions around anything interpreter services, you're welcome to send them in the chat. I'll be responding. Oh, yes, Rima, I just rewatched that episode of Scrubs yesterday where they were speaking to a German patient and his brother did exactly what I described, where they're like, oh, you have cancer. It is serious. And the brother said, you're going to be okay. And they also talked about, yes, make you more comfortable. They described it as having a box of kittens that you just bring and they wander around. All right. I'll resume sharing my slides so that James can talk about his part.
Well, thank you so much, Yuliya. Since there's a good mix of folks, I'm going to go over the CCMs. I know some of you are very familiar with them, but Ethnomed and Community House Calls were sort of born out of the same time, so I want to talk about both programs. So Community House Calls, where the caseworker cultural mediators was created about 30 years ago by a group of medical interpreters and providers here at Harborview Medical Center, who basically noticed that the providers they were working with were woefully unprepared to properly treat a lot of the patients who were coming from, the Vietnam War, the Cambodian genocide, and they realized they needed more than interpretation. They needed to help providers with sort of cultural mediation and understanding the spiritual and needs in terms of mental health that their patients had, and that the patients actually needed a lot more guidance themselves. If they were coming to the US, if they were learning English, if they had a lot of complex issues affecting their case and affecting their ability to adhere to treatment and things, all those needed to be addressed. So the caseworkers were born, and they are medical interpreters. Oh, and we can move on to the next slide. I know it was playing automatically. But yeah, they are medical interpreters. They also do complex caseworker or casework for the patients and follow-up. They are patient and provider educators. We have some who are specialized in certain areas. So we have Nuvis, who works almost exclusively in oncology. We have a couple CCMs who are certified diabetes educators. And then we have JT, who works entirely in surgery and doing that perioperative support for patients. I think when it comes to the CCMs in this area, you're probably going to be more familiar with them if you're coming into our system. If you work at Harborview, I would love to have them at Montlake for this same reason. A lot of the feedback we get in this space particularly is CCM saying, I wish I had been brought in sooner. When it comes to the complexity that you see with Jerry Pally, there can be a lot of pitfalls, as I'm sure you're aware of. Yuliya talked about a few of them. And having a CCM, one of the superpowers that they absolutely have is they're incredible at coordinating a family, coordinating a community, coordinating, the sort of shared decision making that's a lot more common in some of our patient populations with religious leaders or elders, and or helping children understand their parents' care. And I think that when we've seen CCMs brought in sooner, it's usually been a more successful and smooth sort of trip through our system. So that's just a consideration to have, and you can find out more about the CCMs. Well, actually, I will say they are referable in Epic. Again, if you're new to the system, and I will also say, please refer. Even if we don't have a CCM for that specific language, we are always documenting the referrals that we get, and we just added, I think last year or the year before, a Tigrinya CCM. And Abdullah, who represents our Afghan community, came in 3 years ago, and it was all entirely driven by the referrals that we got from providers, just saying and again, I will also say, just documenting really well why you need a CCM. There's showing the complexity and not just assuming that it's going to be approved really helps on the CCM side. So And you can find out about the CCMs more on Ethnomed, which I think is my next slide. Yes. So we have video interviews with all of them. And I think we still need to add Abdullah, maybe. Maybe he's not comfortable. Not everyone's comfortable on film, but so and next slide. I will just say this kind of brings me to Ethnomed as a resource for you. So Ethnomed was born out of the CCM program. It's also 30 years old, maybe 31 now. And it was originally essentially a repository of lessons learned from when providers were interacting with patients with whom they didn't share a language or a culture. And in that time, it's really evolved. We've built 30 plus year relationships with a lot of different community groups in and around Harborview. We've developed, really deep provider toolkits and things like that. And now you can really think of us as kind of the facilitator and the public face of a lot of the work being done out of the International Medicine Clinic, certainly community house calls. And we're really the first port of call for anyone around UW Medicine that wants to partner with refugee, immigrant, and migrant communities to, do public outreach, to do community-based participatory research, and to create patient and provider education materials, particularly if they're a little bit more complex than a translated discharge document. So what do we do? Next slide, please. We have just an array of resources. It's always hard for me to kind of distill the things that we have. In the middle there, you'll see the videos that we have. We have an in-house studio, and we have a pretty good network of providers that speak a lot of different languages. And then we also have access to the CCMs, which is incredible. So, when we get a call to put out, a PSA video from King County about measles because it's in the news a lot, or, we're seeing a lot of confusion around TB, we can turn that around really, really quickly. We're working with the Adult Medicine Clinic to do the same guidance around hypertension, because there's a lot of different issues within separate communities that make adherence to those meds and understanding of treatment more difficult. And then we have some really practical videos that are around, fit testing. We're working with the, pediatric burns and trauma to create some videos around, doing stretches with their hands or doing wound care, because we see a lot lower adherence among our limited English proficient patients. Another example on the right there is, helping providers with Ramadan, giving some resources for that. If you are coming into our system and you haven't worked with patients that are regularly fasting, sometimes for like half the year for, some of our Ethiopian patients, are you comfortable, talking to patients about, how to adjust their medications, or, using like culturally significant foods to manage, their A1C, all of those things we have on Ethnomed. And then, our TB profile, we have really deep projects in that area. Next slide. We also do a lot of outreach. We're out in the community quite a bit. I will say we're going to health fairs, and we love going to health fairs, but I think more importantly for Ethnomed particularly is going directly to the communities for the needs that they've identified. So, in this space particularly, we were just out at the Vietnamese community with dementia friends, and we were talking about, what are the differences between like just the healthy, normal signs of aging that shouldn't concern me as, as an aging person or as a family member of theirs, and what are the things that aren't normal that I can, ask my doctor about really quickly. And in part of that, we're also kind of turning around and advocating for, people in Harborview and people in UW Medicine, our providers, to recognize some of those signs, because there's a lot of well-documented evidence that, signs of Alzheimer's and dementia are not recognized nearly as quickly for patients who do not speak English. And it's just the increased complexity in that room. When you have something going through an interpreter, you might miss those little subtle cues of you might just assume that the confusion that the patient is exhibiting is because they're trying to understand the interpreter, and then their child is on the other side, and things, and you might think, well, I'm confused too. So, but for that reason, we're not diagnosing those things as quickly as they need to be. So advocating for spending a little bit more time and really cueing in to the signs that the patient is giving you is helpful. So going out into the community, we're seeing a lot of the same. I had a really wonderful talk with all the CCMs the other day. And some of the CCMs, like Jennifer Huang or Yodit, who have been with us for almost 30 years, are talking about sort of seeing the progression of their populations, their communities. They started here at Harborview really thinking about maternal child health, and then they've moved into chronic disease. And now, as they're aging, there's so many questions in that space. And it's really kind of providing us a roadmap for folks like Abdullah or folks like Mohammed for Tigrinya speakers or Dari speakers, which is a much younger population, understanding the needs that they're going to have and what kind of resources are going to be very helpful from that by drawing on the incredible experience of some of the CCMs who've been with us a while. Next slide. We also partner with people at all levels of medicine. I love this part because I adore working with students, and we really do work at every point. So Dr. Duncan Reed and I are both advisors for MAPS, the Minority Association of Pre-Med Students at UW, and we at Ethnomed set up a lot of shadowing in clinic for folks. A couple of our mentees just got into med school, and we're very excited for them. One at UW and one at Wazoo. And then at the next level, we have a couple, we have modules and we have some curriculum available at the med school that I think everybody who's there now has engaged with. And we also host resident and fellow projects. So I think we're working with 7 or 8 medical residents right now through 3 different clinics on a variety of different projects. And we also work with students from UW. So I have a couple undergrads, a couple grad students, a couple PhD students, PhD, MD, and again, it's just a wonderful moment where we can kind of give students, medical residents, or even people who have been here for a long time, just the opportunity to kind of partner with different community organizations and create things to either educate other providers, because we do a lot of QI projects too, or educate the community. So it's, we use this sort of metaphor of a bridge a lot, because we go, both ways, internal and external. Next slide. Oh, and I've been talking to a lot of them. I have no idea how many residents or fellows we have here, but we have a lot of different asks that we've had. An American Indian Alaska Native Health Toolkit, that's a little out of our normal scope, but we have had quite a few different calls just because Ethnomed is a place that a lot of providers know when they're looking for sort of tips and advice when it comes to cross-cultural care, and a lot of the same lessons apply. So we've been working with some organizations to put that out. Improving mental health outcomes for conflict survivors. We have a couple people looking into this, but I would always appreciate more. I would really also appreciate a lot more aid for, end of life. It's just a very difficult conversation to be able to distill. And I suppose that in that area, I would lean more towards, engaging our cultural mediators, just because we're never going to be able to distill all the knowledge that they have. But, for some of our patient populations, there's just not a lot of resources available. When we're talking about like the Cambodian community, there's a lot of generational trauma there, and we've heard more and more calls as we've gone out to the community for mental health resources, or people mentioning that they're, afraid for their friends and family and not really knowing what to do. And translated materials, much less sort of in language care in that space is very, very limited. So being able to provide that, or if you have ideas for that, please reach out to us. We would love to partner with you on a project. And then you can see some of the other options we have there. Next slide. Oh, we have, and just some other boilerplate stuff we have. We have a calendar of events. This is very useful for providers, especially just knowing like what, holidays are coming up that are going to affect patients' care, when, different times come around, whether it's Ramadan or whether it's the Great Fast for, a lot of our Amharic speaking patients. We just kind of remind providers to, be asking certain questions around this, make sure we're adjusting medications, make sure we're, talking to patients about their needs during those times. It's very useful. We also have a lot of the community events that you can go to if you are so inclined. If you want to join Ethnomed out in the community, it's a great way to kind of feel better, and especially in this climate, I think getting out into the community and just, talking to a young mom who wants to, has some simple questions about, raising healthy kids is a really fun time, and it's, it's really energizing. Next slide. Oh, and I included this slide. You can look over it at your leisure, but it was just sort of an example of some of the work we did. So we have an intern at Ethnomed this year. She just finished her undergrad. She's pre-med. She's in her gap year, studying and hoping to get into med school. But she did a project with us on specifically the end of life resources and palliative care considerations for different populations. She spoke to CCM. She did an extensive literature review, and there are some really great resources on Ethnomed that kind of talk about those considerations, and those are available to you. Oh, thank you so much. Next slide. Oh, I shouldn't have left that in. I think that's a dead link, but you can collaborate with us. We do have a collaborations page on Ethnomed. Oh, that's from okay. We can move on. That was from when I spoke to the emergency medicine residents. They are collaborating with us right now on, telling communities about e-bikes and e-scooters, because we noticed that during 4th of July, we had more admittances for accidents with people not wearing helmets on those e-bikes and scooters than we did from fireworks, which is really, really unsettling. And so they are going to do some community safety videos in a variety of languages that we're going to put out in a lot of community spaces. So that's just another example of the types of things that we can turn around pretty quickly when there's a need. So, next slide. Oh, we also have the Ethnomed podcast, the Provider Pulse series that's coming out right now. We have a lot of episodes out. Duncan Reed is the host. He's the Ethnomed and Community House Calls medical director. It's really geared towards interviewing people about their cross-cultural journey to and through healthcare and public health, to help folks, particularly MAPS, who we advise, sort of see themselves in the medical profession. If you have residents this year or fellows, I think a lot of them are current residents and fellows at Harborview and in UW Medicine, and they speak really candidly and beautifully, I think, about, the imposter syndrome, about, the trouble in certain rotations, about connecting with their fellows, about not, necessarily having mentors in this space and coming in and trying to sort of forge their own path. And it's a really There's some really beautiful interviews. There's a couple other ones. If you know the mailman, Ken Arning, like he's been here for so long. He knows everyone and he's got a truly fascinating story. And he was the last episode that came out. So there's a few sprinkled in that are just, Harborview legends that people want to know more about. Next slide. We also have a space called the immigration page on Ethnomed. It's where we post quarterly updates on sort of the state of immigration. As you can imagine, right after a certain bill was published, I went to the Refugee and Immigrant Advisory Council at Harborview and really kind of laid out how that is going to affect all of our patients starting in October of 2026 when all of the things happen. There's a lot of good information out there now, but this is really a space where you can just check in on a quarterly basis. You as a provider might definitely don't have time to read an 800-page bill to understand, all of the changes that have taken place. But they are going to affect your patients. A patient that was very calm and comfortable walking in might be walking in with completely different worries, wanting to remove their preferred language from my chart, wanting to not have their visit recorded by our ambient AI system, all of those types of things. And this will help you kind of understand how the landscape has changed, how healthcare access might be changing for your patients, just so that you're prepared going in and you feel like you've gotten that. And that's run by Bailey Conrad, who is co-chair of the Immigrant and Advisory Council, and she works in International Medicine Clinic. Next slide. Oh, and these are just some other UW resources. I put in Bailey's contact. The Refugee and Immigrant Advisory Council, I've name dropped it a lot, but it's a terrific place to come if you have general questions. If you want to start up a QI project, you can reach out directly to Ethnomed, but if you're noticing an issue and you think there might be a solution out there that another clinic could have. Oh, yes, James, we're wrapping up. So yes, I will include all these slides. I think the next ones are general, resources for you if you need to find patient education materials, but you can also check out Ethnomed. Thank you so much for joining us, everyone. This is terrific. I know that we're going to be working with you more. And if you're one of the new folks, welcome to Harborview.
Thank you so much to both of you. This is really helpful, and I just love all of the resources.